Dr. Tina Pierce, with a background in general practice, became a consultant in contraception and reproductive health care in 1996. She then led the Contraception and Sexual Health Service for Surrey for 24 years. She became a key opinion leader in contraception and lectured both nationally and internationally. She gained her menopause specialist qualification whilst working at Gelwest. She now runs the menopause consultancy concentrating on women's health. For the last 6 years, she has had an interest in mast cell activation syndrome and histamine intolerance sparked by a diagnosis of her daughter in 2016. Since then, she has helped many patients with this condition to improve their health and quality of life. More lately, she has been treating long COVID patients. So this is an important topic today, mast cell activation. So please keep an eye on this one, especially for the long COVID. So Dr. Tina Pierce is next. Her background, as I've discussed before as well, in the contraception and reproductive health. And now she has been very important topic, the mast cell activation syndrome. And that is the area which she's going to describe and discuss with us for long hauling state. So Dr. Pierce, please take it away. Welcome.
Thank you very much indeed. Well, I'm delighted to be able to speak to you today. I'm just going to try and share my screen. Here we are. Just go into the slideshow. Here we go. Lovely. Fantastic. So first of all, thank you very much indeed for giving me this opportunity to share my work. After Hector's fantastic presentation, I feel a little shy and nervous, but I will try and follow that fantastic presentation that he did. So what's been happening is treating long COVID. This is a topic very close to my heart. We've got 1.1 million patients in the UK now who have probably got long COVID, and that means that there'll be many, many people all across the world with this condition. And I've been working to a hypothesis, and it is a hypothesis, that what could be causing this. So I feel that, and some other doctors who work with mast cell activation also agree with this, that acute COVID could be exacerbating mast cell activation in patients who have this condition pre-existing, which was hitherto unrecognized and untreated. Also, acute COVID could cause mast cell activation in the minority of patients with long COVID. That is another possibility. And the third possibility is that viral persistence in some cases is continuing to elicit the immune response that is causing mast cell activation. So, what is mast cell activation? Well, this is a condition that is frequently seen in every clinic around the world, but is very seldom recognized. And it's thought that up to 17% of the population actually have got dysfunctional mast cells of one sort or another. And it was first described as a syndrome in the 1990s, and the first treatments were developed since 2007. So it's quite a newly described condition, and therefore it's not on a lot of people's radars. It causes patterns of chronic inflammation in various different systems, with most of the tests being completely normal, but it results in often debilitating symptoms. So patients present with things typically like IBS and food intolerances, chronic headaches. They can have various dermatological presentations such as hives, urticaria, dermatographism. They can have fibromyalgia, they can have POTS, they can present with Ehlers-Danlos loss, hypermobility, interstitial cystitis. There's all sorts of parts of the syndrome that are presentations of hyperinflammation. And these symptoms seem to be caused by cytokines and amines, which are released by the mast cells. As we know, the mast cells release over 1,000 different cytokines, and we don't know what many of them even do. There's so many of them, and the studies and the investigation into this condition is so immature and young that we haven't got very much information. But we do know a bit about some of the chemicals that are released by the mast cells, such as histamine. And we know that histamine causes a lot of inflammation in the tissues, and the histamine intolerance is a frequent feature. Now, I had started developing this hypothesis in August when I started hearing about long COVID patients. And prior to that, I had been thinking that perhaps the patients who were suffering with very severe acute COVID were patients who had undiagnosed and untreated mast cell activation. And that's why they were being overwhelmed by inflammation caused by the acute virus. And that was resulting in them having to end up in ICU. And sometimes dying. Anyway, the International Journal of Infectious Diseases published a paper by Afrin, Weinstock and Muldrings on September the 10th in 2020. And these are the colleagues who discuss and investigate and treat patients with mast cell activation syndrome. And they said that their hypothesis was that the hyperinflammation seen in COVID-19 is consistent with mast cell activation syndrome. The prevalence of severe COVID-19 is similar to that of mast cell activation syndrome. Drugs inhibiting mast cells and their mediators show promise in COVID-19, and none of the patients treated in this way for acute COVID-19 have had severe forms of the disease or mortality. So their treatments were proving to be very successful. Dysfunctional mast cells and mast cell activation syndrome may underlie severe acute and chronic COVID-19 illness. So this is what these colleagues had written in their article, and it's an excellent article. I would really recommend it to everybody. I have been recommending patients who I've come across with acute COVID, which isn't very many, possibly 10, to also take medication as if they had mast cell activation syndrome. And I must say that all of them have started to feel better within 24 hours of using this very simple, safe, over-the-counter medication. Oh, sorry, I have to go back. There we are. The international ivermectin for COVID, the other paper that I'd like to draw your attention to is the paper by Cambridge University published in January 2021. And this paper, they looked at patients who had been in hospitalized from COVID, and then they followed them up with regular testing. And they said that the likelihood that severe and long COVID may be established in the early stages of the disease is highly likely. They felt that asymptomatic, this is what they found, asymptomatic or mild disease is characterized by a robust immune response early on in the infection. So people who are asymptomatic or have a mild form of the disease, they have a good immune system. They have a robust attack of the virus initially, and then everything in their immune system resets to normal very quickly. So a good response and a good reset. Whereas the patients admitted to hospital who have an impaired immune response and a severe inflammation from the time of symptom onset. So those who were admitted seem to have a different kind of immunological response to the virus. Persistent abnormalities were found in the immune cells, and a change in the bodies of the immune response may contribute to long COVID. This overreaction of the immune system causes the cytokine storm and the severe inflammation that can result in organ failure and death. So basically, Cambridge University and Addenbrooke's Hospital, their research found exactly what would substantiate and value what Dr. Afrin and Weinstock and Muldrings had in their hypothesis. So they found that there was mild or no symptoms. Patients with mild or no symptoms had a robust adaptive response, producing B cells, T cells, and antibodies specific to the virus. And then there was a quick resolution to normal with no inflammation. Severe COVID patients, they had a delay in early adaptive response with profound abnormalities in a number of white cell subtypes and evidence of severe inflammation early after onset of symptoms. This response was not initially determined by the viral load. Persistence of the abnormal immune cell types for weeks or months with resolution depending on the type of immune cells. And some cell populations remain abnormal or show limited recovery even after systemic inflammation has resolved. And I would think and hypothesize that these are the patients with the abnormal mast cells in the first place who don't fully recover and don't get back to normal mast cells and normal immune cells. So I decided, having thought about this and worrying about whether these patients actually did have mast cell activation, that I really needed to try and find out. So I went on to BBC News Look East, and this was in October, and I asked patients with long COVID to download a free app called People With, and to put in their symptom profile, because I wanted to see if their symptoms looked like those of my patients with mast cell activation syndrome. And lo and behold, 2,000 amazing people did download their symptoms, and they started recording their profiles, and they were absolutely identical to those with mast cell activation. So then I felt that I really wanted to talk to some of these patients, and I wanted to see if I could help them. So I opened a long COVID clinic, and it was opened on the 1st of November in 2020. And it was fully booked within 36 hours of opening until the 31st of March 2021, which just shows how, with social media, how quickly the word gets around when there is something that might help these patients. Remember that up until now, these patients have been going to their GPs, and they had been sent to various different specialists depending on their symptoms. So those who had cardiac symptoms would be sent to a cardiologist. Those who had GI symptoms, or if they did have those as well, they'd be sent to a gastroenterologist. Then they'd go to a neurologist for their headaches and their neurological symptoms. Then they might see a dermatologist for their rashes and their skin problems. And nobody was sort of looking at them holistically and pulling it together. And by the way, all of their tests predominantly were absolutely normal when they went to all of these specialists. There were only 3 cases in my patients who had myocarditis, so inflammation of the heart muscle, but everyone else's tests were all completely normal. So within a short space of time, I saw 60 patients, and 8 men and 52 women, so predominantly women. And 58 of them, when I took their history, 58 out of the 60 had a previous medical history suggestive of MCAS, of mast cell activation syndrome. And there were only 2 in whom I couldn't find any previous history at all. So this was quite interesting. Well, what are the typical symptoms of MCAS and therefore of long COVID? Well, these are some that you'll be very, very familiar with. So abdominal pain, diarrhea, nausea, vomiting, bloating, food intolerances, typical IBS type symptoms. Then skin symptoms include itching, sudden redness, flushing of their neck and face, rashes, dermatographia, worsening of eczema, psoriasis and rosacea suddenly developing as well. Then cardiac symptoms including palpitations, vertigo, arrhythmia, hypotension, POTS type syndrome, Cohen's disease, which is a very interesting condition of angina without any plaques or narrowing of the arteries caused by any obstructions. So this is frequently described in my patients with mast cell activation, and some of the patients with long COVID are now describing this. Also, patients could have runny noses, sneezing attacks, asthma, and shortness of breath. But often their asthma doesn't respond to typical inhalers because it has a different mechanism. Then headaches, migraine, sweating, freezing, menstrual pains, fibromyalgia, tingling sensations, brain fog, anxiety, panic attacks, insomnia, fatigue, post-exertional malaise. This list is not exhaustive. Unfortunately, there are many, many more symptoms. And in fact, I think on the People With app now, 8,000 people with long COVID have downloaded the app, and they are describing about 109 different symptoms that they've experienced. So it's a massive number of symptoms. So how have I been treating them? Well, what I've been doing is I've been treating them as for my mast cell activation patients. So I put them on a low histamine diet. And that is because we know that their histamine levels will be high if their mast cells have been stimulated. And I have found that many of the patients have very poor metabolism of histamine, and therefore allowing them to continue eating high histamine seems to delay their recovery and make them much worse. So going on a low histamine diet is, I think, very, very helpful. I then put them on type 1 antihistamines. So one of the following: loratadine, cetirizine, fexofenadine, anything that we can get hold of easily. They can buy in the UK loratadine and cetirizine over the counter. So, and fexofenadine is also available over the counter, actually up to 120 milligram tablets. So we have to try each one for 2 or 3 weeks and see which one suits them best, but they have to be given in the right doses. So the loratadine and the cetirizine would be 10 milligrams 3 times a day, not just once a day, as would say on the packaging that they would buy. The fexofenadine can be given up to 4 times a day at 180 milligrams. Then type 2 antihistamines, famotidine, which is the strongest one, and nizatidine. We used to have ranitidine available, but unfortunately that was taken off the market, which is a great loss because it was very, very helpful. And then a mast cell stabilizer, I usually give them ripatidine or ketotifen. And if they have predominantly gut symptoms, sodium chromoglycate can be very helpful. Then there are various other supplements that they can take. I like them to take a probiotic that is a low histamine one, and to get their microbiome as healthy as possible. Also vitamin C and D and niacin, vitamin B3, and then selenium, zinc and magnesium, also very helpful. And I would love to give them all ivermectin. So I've put it there at the bottom of my list. I have given 3 patients ivermectin and they've all responded very well, but possibly we haven't persisted with it for long enough because their symptoms have returned, but not as bad as they were in the first place. So I think I'd be very interested in now adding ivermectin to my list, but giving it more consistently like Hector has. So this is just my last slide. I'm actually organising a conference which is going to be the 19th and 20th of June, and it's going to be on how can we treat long COVID, and Hector is going to be speaking at that conference as well, which I'm just inviting anyone who's interested in learning more about it, then please do join us. Part of the workup that I do with my patients is we've been doing their genetic testing, and we found that there are certain themes that are very common to patients who have long COVID, and we'll be presenting those at the conference. And also we've been doing a lot of their microbiome testing, and again there are certain things that keep coming up as occurring very more commonly than you'd expect in the general population. So thank you very much for listening.
Thank you so much, Dr. Pierce. What an important topic, and thank you very much for such a thorough and fascinating coverage of it. I feel that the worst outcome, other than, so there is so much lives lost that it is unbelievable and that is tragic. And a tragedy that is now unfolding is the long haul state, because this is going to make people, and it is making people, miserable for a longer period of time. I have heard from my patients that I just don't have any interest in living with this situation. So thank you very much for doing this work, and thank you to Dr. Carvalho as well for his work. A few questions here. Actually, there are a lot of questions. I'm going to try to do as many as I can. So first of all, what is that app? Is that app still available? Should people still be using it and get in contact with you with that? Can you mention the app that you were offering?
Yes, so the app is called People With, and that's written as one word, and it's free and it's available in many parts of the world. I'm not sure that I can say everywhere, but I know it's available in America and Europe, most of Europe, in the UK. And people can download it. Their information is confidential on the app, but they can track their symptoms, they can load them on, track them. It's a lovely app actually, because it also reminds them to take their vitamins and minerals and their medication and so on, and they can sort of put in their lifestyle, exercise and etc. So it's very helpful for patients, and it helps them to see if they're getting better. They can also download a report and send it to their doctor to see improvement, because sometimes it's not easy to remember how well you were or when you had, exacerbations of your symptoms.
Got it.
And that is something that happens with these long COVID patients. I'm sure you found the same, Dr. McBean, they can relapse. You know, they felt a bit better after a
Yeah.
few months, and then they overdo it and they go back to their exercise regime, or they try to get back to completely normal life, and then they're knocked sideways and they end up with all the symptoms again, which can be very frustrating and demoralizing for them.
Absolutely. And I want to add a comment here from Dr. Carvalho for the doctors who are listening in. Um, Adding ivermectin during the treatment, or what I've seen is that in addition to ivermectin, if you feel that somebody is going to become long COVID, if they are slowly recovering, then adding a low steroid dose therapy is also very useful, and it protects the patients. Dr. Pierce, next question. What is low histamine diet?
Okay, so it's quite restrictive. It means no histamine blockers, that's diamine oxidase enzyme blockers. So no tea, no coffee, no alcohol, and no green tea are the first thing to say. The second thing is it means excluding things like tomatoes, avocados, spinach. It means not having citrus fruits. You know, it's easier to say what you can have than what you can't have, actually, because it's a
Wow.
much smaller list. But there's quite a lot on the internet about low histamine diets. There are lots of conflicting lists, so it's a bit difficult. But there is a very good website, which is the Swiss website. It's called Histamine Intolerance by the SIGI group. That's the Swiss interest group in histamine intolerance. And they've got quite a comprehensive list of foods and spices and drinks, etc., that you can check your shopping list against. Yeah, but it's really helpful to exclude the high histamine foods.
Got it. Thank you very much. Next question. So there are some long haulers who have brain fog, myalgias, fatigue, difficulty in focusing. Have you used fluvoxamine or some other such drug with the other treatments?
No, I haven't personally, but some of the patients already come on them when they, by the time they've seen me, because often they've had the condition for about a year and they've been given some antidepressants because they're quite literally very depressed by that stage. And most of them have said that they found them very helpful. So it's usually, it's not something that I've instigated, but it's something that my patients often come and they're already on them.
Got
And
it.
they comment that they find them helpful.
Got it. And so on fluvoxamine, there is a question as well that I want to read out. And this is something Dr. Corey, if he was here, he would have answered it. I'm going to, at the risk of representing him, which I cannot really very correctly, but I'm going to answer this question. The question is, why fluvoxamine is the new guideline? I think they're talking about IMAS Plus. Patients in psychiatric hospitals get neuroleptives, etc., every kind of medication. What is the rationale in Pierre Corey's prescribing on an antidepressant? I am not happy enough with the current explanation. Thank you. I am a psychiatrist. I would like to understand better. So, of course, if Dr. Corey is here, we would have his question. We would reach out to him as well. Some answers that I have found out. So there is a study that was done about fluvoxamine in which they used fluvoxamine not for depression, but as a sigma-1 blocker, and that would reduce the inflammation. So think about ivermectin reducing inflammation in the body, and it is not crossing the blood-brain barrier and going to the brain. So if you wanted to have a similar effect in the brain, then fluvoxamine can go and work with the sigma-1. So that was the basic study's outcome, and they had a tremendous significant result with that. I have actually discussed that study as well. So I believe that rationale for adding fluvoxamine is that. However, again, I am trying to uh, add color from my side. This may not be the reason. We'll reach out to Dr. Corey as well. So continuing with the other questions, one question that is really important is, Dr. Pierce, why is MCAS? So MCAS is still a wonder for a lot of the medical community. Some folks even say that this does not exist. Some actually have. You are practicing it. I have talked about this as well. Why is it so difficult to, number one, test for MCAS and manage it?
It's very difficult to get colleagues to take an interest and accept it, because all the tests are usually normal. That's the first thing. The tests are usually normal because the laboratories that we use commonly for our patients haven't got enough machines with enough sensitivity to detect the small changes that will be needed to make the diagnosis in some of the chemicals. Now, the chemicals released by the mast cells are very potent chemicals, and they're designed to be very potent, and the body wants to get rid of them very quickly, therefore. So they're supposed to be there when you have a virus, get rid of them quickly, and then everything back to normal. And so therefore, they're ever-changing levels in the body. And if you take a sample and it's not handled properly, it's very difficult to see those chemicals in that fleeting moment. So it's incredibly difficult for us in the UK, especially, to prove to the other doctors, look, these are their abnormal results, because they all just sort of come back normal. There's one lab in Bonn in Germany, in the whole of Europe, that can detect the changes in heparin level that are required to make the diagnosis. This is just not very, so it's very basically a clinical diagnosis that we are making. Sorry, what was the other part of the question, Dr. Mabeen?
So this was the main question, that why is it so difficult to understand it? And then why is it so difficult to manage it? Is it just the understanding that it exists and that is why we don't manage it, or management itself is tricky as well?
The management is quite tricky too. You have to be very patient, and the patient has to be very patient. And often patients don't really want to change their diet and their lifestyle very much, but when they do, they find the benefits are amazing. And then when they have weaknesses and they give in to a glass of wine, they often pay for it, and then they start to see the sort of method and the reason for restricting these things. But you have to be very patient as well, because the patient's immune systems can become so oversensitive that they're sensitive to excipients in the medication, not necessarily to the drug, but to the excipients. And therefore you have to keep trying different ones to find the one that's best for them. So it requires a very patient and methodical approach.
Got
But
it. Thank
some
you.
patients respond really quickly. I've had patients who've got better within a week. And they're and others by their 6-week checkup are 80% better, 90% better, so it's definitely worth doing.
So perfect segue in my last question, and you already answered it. So Mirali Fanous had this question, Dr. Pierce, on average, how long before patients start seeing improvements on an antihistamine diet? How long would you keep them on it? So you almost touched on it. Any further expansion on this?
So I mean, some patients start to feel better within days. Some it takes a bit longer. Some patients end up feeling better than they did pre-COVID, because they had undiagnosed and untreated mast cell activation, which is always very gratifying. And I would keep them on the low histamine diet for probably about 6 months, and then gradually start to, until they're stable, and then gradually start to reintroduce foods one at a time and slowly, so that they don't overwhelm their system. As I said, many of these patients, we think that about 20 to 30% of the population have problems with their genetics, in as much that they don't metabolize histamine very efficiently. And so if your body is overwhelmed with histamine, you're not going to handle it very well. And staying on the low histamine diet can help to keep those levels down. But hopefully then things settle down. And and another treatment, actually, I forgot to put on my protocol, is for them to have neuroplastic retraining of their brain. So I actually recommend that they do something like the Gupta program to help retrain their amygdala and insular parts of their brain to calm down their immune system.
Got it. So thank you very much. Fascinating area, important area, critical area to help. And thank you very much for the help that you're doing. So audience,